Hello, this is Captain Mark Albright, and I'm here to talk to you today about severe tracheomalacia, an intraoperative case study. Here's an outline of everything I'm going to discuss. So, this is a case study which describes a non-cardiac, non-obstetrical thoracic procedure, surgical case of a 63-year-old man with tracheomalacia. Additionally, we'll talk about etiologies, manifestations, contemporary treatments, and provide discussion of the case's challenging and supporting literature. It is imperative that anesthesia providers understand the anatomical and physiological changes associated with tracheomalacia to safely plan and implement one-lung ventilations, because as you can see, they have obscured tracheal anatomy. And tracheomalacia is a condition in which the tracheal and the bronchial cartilages soften and narrow. Here's a little bit about the etiology. Tracheomalacia can be congenital, such as tracheoesophageal fistula in children, or it can be from chronic inflammation, anything ranging from recurrent infections, chronic bronchitis, prolonged endotracheal tube placement, tracheostomies. It's basically a pathological condition in which elastic fibers of the tracheal membrane has occurred, leaving the lumen with a smaller transverse and sagittal diameter. So essentially, it makes the cartilages not act like cartilage. It loses some of its rigidity. There's a dynamic process here where you can see in the picture of a normal trachea on inspiration and expiration. You can see a little bit of narrowing on expiration. However, with tracheomalacia, it's much more significant, and even on inspiration, you can see the narrowing has occurred. So it's a dynamic process, almost akin to atelectasis in the upper airways. I don't know if you guys remember the physics of the law of Laplace, but basically the softening and thinning of the cartilage leads to a thinner wall, which increases the tension, which leads to collapse. Manifestations. Manifestations of tracheomalacia are related to the dynamic narrowing of the posterior anterior walls during forced exhalation. This narrowing is more likely to occur in patients under stress, such as a patient under the influence of anesthesia. This dynamic creates an obstructive process that can lead to coughing, sputum retention, and dyspnea. Wheezing and stridor can also exist, which can be confused for increased severity of other disease processes such as asthma or COPD. And the true way to diagnose this is through a bronchoscopy or under MRI. So it could be confused for other pathological conditions. Treatment. Long-term therapy candidates usually have surgical repair or stenting. There is a temporizing treatment, which is more pertinent to the anesthesia provider, that of CPAP. So whenever the patient exhales, you maintain those upper airway patency with continuous positive pressure, and this facilitates open airways and the drainage of secretions. So how do you prepare to do the anesthetic for a patient with tracheomalacia, whether it be a thoracic case or a non-thoracic case? Well, a detailed respiratory physical assessment. You want to observe pulmonary function test if available. You want to prepare for the sequelae of tracheomalacia on induction and emergence, that being the airway closure. Plan for weaning off of mechanical ventilation. They may be more difficult, and they may require prolonged mechanical ventilation after the surgery. Also, it's important to realize that subglottic landmarks may be obscured upon upper visualization, fiber optic visualization, and you would also want to be more careful placing any kind of tube or probe into the trachea, which could cause further damage. So let's get into the case study. So this was a 63-year-old male, ASA4, roughly weighing about 100 kilos, who presented for an unstable thoracic T8 burst fracture. His history was that he sustained a fall 1 year prior, which had left him with persistent back pain, periods of transient leg weakness, which led to more falls, and a neurogenic bladder. The patient desired a spinal fusion with instrumentation requiring both a posterior and an anterior approach. A discussion between anesthesia and neurosurgery and the thoracic surgeon revealed a left anterior approach, which would require one lung ventilation for the beginning of the procedure and a prone position for the end of the procedure. So upon assessment, breath sounds had scattered rales and wheezes. He was an active smoker. He had a history of asthma. He had COPD, and he had a prior tracheostomy that led to his tracheomalacia. Cardiovascularly, he had a regular rate and rhythm. He had a history of controlled hypertension. He had a history of 2 MIs requiring bare metal stents 3 years prior. He had an EKG which showed a normal sinus rhythm. He did have a reassuring stress test, a recent stress test. Preoperative vital signs are as visualized here. You can see a little elevation in blood pressure and a decrease in his SAT on room air. His airway exam was unremarkable. Labs were within normal physiological limits with the exception of albumin, which was slightly lower. Getting into the case, we placed a 22 gauge peripheral IV in the OR. Patient was denitrogenated while ASA standard monitors were applied. In addition, a radial artery blood pressure line was placed and zeroed. Vital signs were checked prior to induction and were deemed acceptable within the normal limits. And IV induction with 4 milligrams of midazolam, 250 mics of fentanyl, 30 milligrams of metomidate, and 20 milligrams of cisatric curium. A 39 French left-sided double-lumen tube was placed. It was inserted past the vocal cords without difficulty. Capnograph showed chest rise with bilateral breath sounds, which confirmed placement in the trachea. The patient was then placed on volume-controlled ventilation while the tube was secured, and maintenance anesthesia was with sevoflurane and a remifentanil infusion. The patient was placed in a Trendelenburg position, and the cardiothoracic surgeon placed the left subclavian cordis under sterile technique in preparation for the anticipation of possible large volume of blood loss. Multiple anesthesia providers concomitantly attempted to verify placement with a double lumen tube with the aid of a fibroscope. Eventually, after the cordis was placed, multiple providers had attempted this and were all unsuccessful because of obscured anatomy. The carina could not be visualized with the left and right side, and no tracheal rings were observed. Because of this, it was unclear to the anesthesia provider if they were in the right or the left main stems. Anesthesia providers intubated with an 8.0 endotracheal tube to a depth of 24 centimeters at the gun line. After this, a 7 French Fogarty catheter was placed in the left main stem under fiber optic guidance through an endotracheal tube. This Fogarty catheter hoping to be placed and used as a bronchial blocker. The Fogarty was inflated and the patient had unilateral breath sounds on the right side. It appeared to be a successful intervention for one lung ventilation. The patient was then positioned in the right lateral decubus position and was secured by the vacuum beam bag. The patient was then prepped, draped, and prepared for incision with a left anterior approach. After incision, it was noted that the left lung was ventilated under positive pressure ventilation. A fiber optic exam under SUD revealed the Fogarty catheter had ruptured. Remnants of the balloon were suctioned out of the left main stem successfully. A team was fostered by the anesthesia team and the surgeon to advance the endotracheal tube under fiber optic guidance into the right main stem. And this intervention was successful, and one lung ventilation was maintained for the duration of the lateral decubitus portion of the surgery. After the thoracic approach was complete, the patient was placed in the prone position after the endotracheal tube had been withdrawn to the 24 centimeters it had originally been placed at. Double lung ventilation underwent. The patient had no further complications. There was not a significant amount of blood loss. Following the procedure, the patient was left intubated and transported to the ICU because of his chronic respiratory diseases and because of the length of the procedure. The patient was weaned from mechanical ventilation overnight and extubated the next morning with no significant morbidity. The total surgical time was 6 hours and 55 minutes. The total anesthesia time was 6 hours and 40 minutes. You can notice a large disparity there. The total time spent attempting to maintain or to attain one lung ventilation was estimated to be about 2 hours. So discussion of the situation and how to best facilitate one lung ventilation in patients with tracheomalacia. It should be noted that facilitating surgical exposure is only considered a relative indication for one lung ventilation. Double lumen tubes are the most common and the most familiar technique to most providers for one lung ventilation when it's required. Bronchial blockers are a close second. However, in relationship to this case, or cases with tracheomalacia, it could be discussed that double lumen tubes have some severe limitations, such as difficulty with insertion and placement in patients with an abnormal upper airway. Other things to consider would be that the double lumen tube requires exchange to a single lumen tube at the end of the surgery, especially for a patient being placed in a prone position following the first approach. At the end of the surgery, if post-op ventilation support would be required, they would also need a single lumen tube. This might also be problematic for the case presented because the patient was prone for 2 hours. Laryngeal and facial edema could have occurred, leading to a worsening airway, which could have made reintubation more difficult. Lastly, double lumen tubes are associated with more airway trauma. They are larger and they have more surface area with the endobronchial tree, and could have worsened his already present tracheomalacia, which is something we would not want to do, leaving this patient worse off following the procedure. Limited evidence suggests that bronchial blockers may be a better choice in patients with significant TM, since they are just as effective at providing one lung ventilation. In this case, a Fogarty catheter was attempted in place of a bronchial blocker because the institution didn't have bronchial blockers at the time. So in conclusion, effective one lung ventilation was achieved using a fiber optic assisted right main stem intubation due to failure to pass a left and right appropriately sized double lumen tube in a patient with a distorted lower airway. A Fogarty catheter was placed as a substitute for bronchial blocker. Unfortunately, the Fogarty presented an equipment malfunction. After review of the evidence, evidence suggests that bronchial blockers could have provided safe one lung ventilation with the least amount of trauma to the patient with significant tracheomalacia, and may have, if present, decreased the total anesthetic time for this patient. This is my contact information if you have any questions. These are my references.